So far in this chapter, we've talked about many of the pathophysiologies that can affect the heart valves. Let's finish up this chapter on valvular diseases by talking about one last condition, endocarditis. Get ready to hear an epic tale as old as time, as we tell a story of the beast with a heart of flame. Endocarditis is defined as inflammation of the endocardial surface of the heart. At Sketchy, endocarditis is represented by our recurring symbol, the lantern with a heart-shaped flame. For the most part, when we use the term endocarditis, we actually mean infectious endocarditis, an infection of the endocardial surface of the heart. IE is the most common cause of endocarditis and is usually caused by a bacterial infection. Hence our recurring sketchy symbol, the bacterial lantern strung up over this old-timey town square. Regardless of the pathogen responsible, the pathogenesis of infective endocarditis is the same. Abnormalities on the valve surface provide a nidus for circulating microorganisms to land, forming a growth on the endocardial surface known as a vegetation. Vegetations are represented by these potted plants hanging from the lantern. Don't let their cuteness fool you. They can become floating death buckets, causing the symptoms and signs that we'll get into in a moment. Of course, endocarditis isn't always caused by infection. Non-bacterial thrombotic endocarditis is a rare condition characterized by the deposition of sterile platelet thrombi on heart valves, hence the non-bacterial clumps of hay spilled all over the ground. NBTE is most commonly associated with advanced cancer, represented by the recurring sketchy symbol, the cancer crab. Another association you'll need to remember is between NBTE and systemic lupus erythematosus, a condition known as Libman-Sachs endocarditis, represented by the recurring sketchy lupus wolf running through these potato sacks, spraying hay all over the place. Since we're talking about thrombotic endocarditis, endothelial injury in the setting of a hypercoagulable state is thought to be critical for its development. This combination of factors triggers platelet deposition on valve cusps, forming the characteristic thrombotic vegetations of NBTE. We won't talk too much more about NBTE in this sketch, since it's super rare and treated completely differently. What you need to know is if your patient has endocarditis, but no evidence of infection. Think about NBTE and its causes, cancer and lupus. Alright, enough pathophys. Let's talk about the clinical presentation of endocarditis and what you should be looking for in your history. We'll focus on IE for most of this sketch since it's much more common. Fever, represented by the recurring sketchy symbol, the flame bandana, is the most common symptom of IE. Whoa, fever and an infectious process? I know, your mind's blown right now. It's alright, I'll give you a moment to recover from the shock of that doozy. In addition to fever, many of the other clinical manifestations of IE depend on the time frame of the infection. So make sure to pay attention to how long your patient's symptoms have been going on. Infective endocarditis can be classified as acute or subacute. Acute IE presents as an acute, rapidly progressive infection, with symptoms like fever, chills, and malaise developing over the course of a few short days. Acute disease is represented by the recurring sketchy alarm clock, ringing acutely. Subacute IE, on the other hand, is represented by this alarm clock, which hasn't gone off just yet. Subacute IE occurs over weeks to months and consists of low-grade fever, represented by this woman's flame bandana, and nonspecific symptoms like anorexia, weight loss, and fatigue that seem to smolder forever, just like her slow-burning, smoldering torch. Unsurprisingly, IE is associated with a broad array of systemic complications, and sometimes patients may present with symptoms of these complications, so let's go through a few of the most common ones. As you might expect, stuff growing on valve cusps makes them less effective at, being valves. Severe valvular dysfunction caused by endocarditis inevitably leads to heart failure, represented by the recurring sketchy symbol, the floppy heart balloon. Make sure to ask your patient about classic heart failure symptoms like dyspnea on exertion, orthopnea, and lower extremity edema. For more details on the clinical presentation of heart failure, check out our chronic heart failure sketch. To make things worse, the vegetations of IE don't always like to stick to the valve. Pieces of them can break off, just like those flaming pieces of that broken potted plant. Told you they were floating death buckets, becoming emboli that cause end organ damage wherever they get stuck. The specific symptoms, of course, depend on where these emboli end up. One particularly terrible location for embolization is the brain, represented by the flaming debris landing on this poor woman's head. Emboli to the brain can manifest as embolic stroke, brain abscess, or intracerebral hemorrhage. So ask your patient about weakness or changes in sensation, vision, or speech. Emboli can also wedge themselves in the mesenteric vessels, represented by this unfortunate woman's mesentery-like dress under attack from flaming debris. Oh, I see. Fashionable and functional. Anywho, mesenteric emboli can cause acute mesenteric ischemia, which classically presents as acute abdominal pain out of proportion to exam findings. The mesentery isn't the only visceral organ that can be affected. Other organs, like the spleen and kidneys, are also potential sites for septic emboli. Last but not least, emboli to the lungs can cause the most well-known embolism of them all, pulmonary embolism. PE, represented by the recurring sketchy symbol, the bird's nest in that lung-shaped tree, classically presents with tachypnea, dyspnea, and pleuritic chest pain. Check out our PE sketch for more info on the clinical manifestations of pulmonary embolism. As mentioned previously, make sure to ask about a history of cancer or lupus, since those conditions are associated with MBTE. While endocarditis can occur in the absence of known abnormalities in the valve, having a pre-existing structural cardiac abnormality greatly increases the risk of IE by providing those pesky microorganisms with a place to grow. Make sure to ask your patient about a history of valvular disease or congenital heart disease, among other cardiac conditions. The baby in the heart-shaped window next to the broken leaky stove valve should help you remember these risk factors. Looks like mom is really looking forward to the end of maternity leave. In order for IE to occur, bacteria have to be circulating around the bloodstream to begin with. That's the second part of the endocarditis recipe, bacteremia. In particular, poor dentition and IV drug use are associated with increased risk of IE. One of the most common sources of bacteremia comes from an unlikely source, the mouth. Poor dentition, represented by that cracked, dirty tooth, allows oral flora to seed the bloodstream and increase the risk of IE. Furthermore, invasive dental procedures, beyond your routine dental cleanings that is, can stir up those mouth bacteria and send them into the circulation, making those procedures risk factors for IE as well. IV drug use is a major risk factor for endocarditis because it gives bacteria from the skin direct access to the bloodstream. IV drug use is represented by the recurring sketchy symbols, this IV-covered mortar and pestle sign. Since we're talking about IV drug use, it makes sense that Staph aureus, a common skin organism, is the most common cause of IE in these cases. In addition, some illicit drugs may cause endocardial damage, predisposing to subsequent infection. And since we're talking about intravenous drug use, it makes sense that the right side of the heart receives the brunt of that damage, explaining why IV drug users more frequently present with right-sided, that is, tricuspid, endocarditis. Arguably, more specific than the history are the classic objective findings that can clue you into the diagnosis of endocarditis. So follow along as we look and listen. Hear that? Nope, it's not the rumbling of an entire village out to kill a misunderstood beast. Close though. A classic physical exam finding in IE is a new heart murmur, so listen closely. In fact, the combination of a new murmur and unexplained fever is IE until proven otherwise. As you might imagine, the murmurs caused by IE are most commonly regurgitation murmurs of valvular insufficiency. As we mentioned earlier, clinical manifestations reflecting the complications of IE may be present at the time of initial presentation. So be on the lookout for exam findings suggestive of those complications, such as elevated JVP in heart failure, focal neurologic deficits in embolic stroke, splenomegaly in splenic infarction, and tachycardia in PE. Uh-oh, get up, guy, or you're gonna get trampled. See those tiny purplish specks of dirt on this guy's skin? They represent petechia, a common cutaneous manifestation of IE. And those wood splinters over the door he tripped over? They represent splinter hemorrhages, which are non-blanching linear reddish-brown lesions under the nail bed. Petechia and splinter hemorrhages are common, but pretty non-specific. On the other hand, Janeway lesions, Osler nodes, and Roth spots are rare exam findings that are highly suggestive of IE. Janeway lesions are non-tender pinkish macules appearing on the palms and soles that can be seen in acute IE. They're represented by the pink spots on this young lady's white gloves, as she struggles to convince the angry mob that the beast is actually harmless, and that it's not just the Stockholm Syndrome talking. Janeway lesions reflect microabscess formation with neutrophil infiltration of capillaries. Ouch! Those burns on Dr. Osler's hands aren't going away anytime soon. Fortunately for us, they're here to remind you that Osler nodes are tender violaceous nodules seen on the pads of fingers and toes. Well, no wonder you burned yourself, Dr. Osler. Can you see anything through those huge goggles? Either way, those goggles with white lenses and red rims represent Ross spots, which can be found on fundoscopy and appear as pale spots on the retina surrounded by an erythematose margin. Both Osler nodes and Roth spots are the sequela of immune-mediated vasculitis. See how the tools in the workshop look like antibodies? In contrast to Janeway lesions, they are more classically associated with subacute IE. Before you leave the room, don't forget to perform a thorough dental exam. Look for signs of poor dentition or active periodontal infection. Basically, this dude's mouth, as those findings can raise your suspicion for IE. With your physical exam complete, let's turn our attention to the tests you'll commonly order in a patient with suspected endocarditis and what they might show. Since we're talking about endocarditis, it makes sense that you'd see evidence of inflammation in patients with IE, such as leukocytosis, represented by the recurring sketchy symbol, the elevated white birds, and an elevated ESR or CRP. While you can order a million tests that may raise your suspicion for endocarditis, we will focus only on the two that play a role in diagnosis: blood cultures and echocardiography. Blood cultures help us document bacteremia. If you suspect IE, however, you've got to be pretty specific about how you order those cultures. Obtain 3 sets of blood cultures, aerobic and anaerobic, illustrated here by the stack of 3 circular dishes on the cart, from separate venipuncture sites before starting antibiotics. In addition, the culture samples need to be drawn at least 30 minutes apart. Let's talk about the different bacteria known to cause IE, because you'll often be tested on the bacteria that are more common in patients with specific risk factors. Let's start with the most common cause of infective endocarditis, Staph aureus. Staph aureus, represented by the recurring sketchy symbol, the golden staph, is the most common cause of IE overall, accounting for 1/3 of all IE cases. Staph aureus most commonly causes acute and sometimes fulminant endocarditis. You definitely won't miss these patients when they present. Like we mentioned before, Staph aureus is the most common cause of endocarditis in IV drug users. Staph aureus is also one of the most common culprits in patients with artificial ingredients, like indwelling catheters, implanted devices, and prosthetic valves. Hence this guy's very artificial prosthetic arm. Pretty advanced tech for these times, huh? Speaking of artificial ingredients, coagulase negative staph species, represented by this non golden staph, such as staph epidermidis, also tend to affect patients with prosthetic valves and indwelling devices. Hence the prosthetic arm on this dirty, surly gent who happens to be holding that non golden staph. However, staph epi causes subacute IE rather than the fulminant acute endocarditis that typically occurs with staph aureus. In patients with native heart valves, Viridans group streptococci, represented by the green stripes on this guy with bad teeth, are the most common cause of IE. Those stripes are green because the word viridans is derived from a Latin word meaning green. Viridans group strep, such as strep sanguinus and strep mutans, among others, are classically found in patients with poor dentition or who have recently had dental surgery, like this guy. Just a few holes to fill in that smile of yours. Alright, ready for a weird one? See Bessie here with her purple striped blanket? She represents strep bovis complex, also known as group D strep. Strep bovis complex endocarditis is associated with colon cancer and inflammatory bowel disease. So make sure to order a colonoscopy to look for these conditions if your patient's blood culture comes back positive for one of these bugs. Staph and strep accounts for the majority of cases of IE. However, there are a few other causes that you'll need to know about too. Enterococcus is a rare cause of endocarditis, and you need to be aware of it because it's classically associated with urosepsis from nosocomial UTIs. Hence this carefree villager playing his purple enterococcus-shaped bongos. He's so relaxed he doesn't even notice he's sitting in a puddle of his own urine. An ideal we can all aspire to? And now, everyone's favorite. The notoriously fastidious and incredibly rare Hayseck organisms. Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella are classically associated with subacute endocarditis, especially if initial blood cultures are negative. To remember, just think about this hacky sack. The negative sign on it is there to remind you to think of Hayseck organisms when blood cultures are negative. Last but not least, we're leaving the kingdom of bacteria and heading into fungi. As you can see by this flag, endocarditis caused by fungi such as Candida can occur in rare instances. Never realized this story occurred in the land of the North. You learn something new every day. Specifically, we're talking about immunocompromised patients, represented by the recurring sketchy symbol, the kid on crutches. Suspect Candida endocarditis if your patient isn't improving after prolonged antibiotic therapy. Phew, I'm tired of talking about bugs. Let's move on to the other cornerstone of diagnosis, echocardiography. Echocardiography, represented by the recurring sketchy symbol, the heart-shaped megaphone, is the imaging modality of choice for endocarditis and should be performed in all patients as soon as you suspect it. The key things to look for on an echo are vegetations, abscesses, new prosthetic valve dehiscence, or new valvular regurgitation. In most patients, a transthoracic echocardiogram, aka TTE, will be your first step. However, if you have a strong suspicion for IE, follow up with a transesophageal echocardiogram, aka TEE, which is more sensitive than the TTE and can better characterize the lesion. Blood cultures and echo form the main pillars of testing for endocarditis. Let's wrap up this section with a couple other tests you might run into. Remember our discussion of Osler nodes and Roth spots from earlier? Those are examples of immune complex deposition provoked by IE. Well, this can occur in the kidneys as well, producing a glomerulonephritis, which classically manifests on a urinalysis as RBC casts, represented by those spilled tomatoes next to that cup of suspiciously yellow liquid. Don't be surprised if you see an ECG on your patient with suspected IE. The most important ECG finding to look for in a patient with suspected IE is AV heart block. represented by this heart on this woman's shield. AV block usually manifests as a prolonged PR interval, or dissociation between the P wave and the QRS complex. For more details, check out our sketches on bradycardia. Heart block in the setting of a suspected IE suggests the formation of a perivalvular abscess, represented by this hat shaped like a bright red abscess with those leafy valvular brims. Need a refresher on interpreting ECGs? Check out our ECG how-to sketch. Alright, we've collected all the data. Let's diagnose this thing. Infective endocarditis should be suspected in patients presenting with fever and relevant risk factors, be they cardiac, such as prior history of IE, structural heart disease, or prosthetic heart valve, or non-cardiac, like IV drug use, poor dentition, or a recent dental procedure. To make the diagnosis of IE, we rely on the modified Duke criteria, which are based on clinical manifestations, blood cultures, and echocardiography. Let's go through how to use them. The modified Duke criteria are divided into major and minor clinical criteria. So we'll divide them into this major Duke fella and his minor assistant. The two major criteria are evidence of sustained bacteremia and evidence of endocardial involvement. Sustained bacteremia is defined as at least 2 separate blood cultures positive for the typical causes of endocarditis, like Staph aureus, Strep viridans, Strep bovis, Enterococci, and the Hay-Sec organisms. For organisms that are more commonly skin contaminants, like Staph epi, you'll need at least 3 separate blood cultures to rule out the possibility of contamination. Finally, a single positive blood culture for Coxiella burnettii also counts. Endocardial involvement can include evidence of a vegetation, abscess, new prosthetic valve dehiscence, or new valvular regurgitation. Moving on to the Duke's bumbling minor assistant. The 5 minor criteria are less specific for IE. That's why we call them minor. They include predisposing conditions for endocarditis, such as IV drug use, prosthetic valves, or pre-existing structural heart disease. Fever higher than 38 degrees Celsius. Evidence for septic emboli, such as PE, stroke, or Janeway lesions. Evidence of immune complex deposition, such as Osler nodes, Roth spots, glomerulonephritis, or a positive rheumatoid factor. And positive blood cultures that don't meet the major criteria for sustained bacteremia. Those are the criteria. Now here's how you use them. Check out the Duke's 2 fingers pointing at the beast. That represents the first way you can diagnose infective endocarditis, if your patient meets both of the major criteria. 1 major and 3 minor criteria also work, hence these fingers here. Finally, if your patient doesn't meet any of the major criteria, but meets all 5 minor criteria, represented by the minor assistant's 5-fingered salute, that also works. Woohoo! You've diagnosed IE. Let's sum it up for your attending with a sample assessment statement. Madame Villeneuve is a 40-year-old female with a history of mitral valve prolapse who presents with 3 weeks of fever, chills, and malaise. 1 month ago, she had a tooth extracted by her dentist. Physical exam is significant for a temp of 38.5 degrees Celsius, poor dentition overall, and a previously undocumented 3 out of 6 systolic murmur best heard at the apex. Her fever and new murmur of mitral regurgitation in the setting of recent dental manipulation is concerning for infective endocarditis. Great, what now? Said every attending ever. Well, your patient has infective endocarditis, so antibiotics. We're talking big gun, broad spectrum antibiotics here. There's no messing around when you're dealing with endocarditis. In general, empiric antibiotic therapy should be started as soon as those 3 sets of initial blood cultures from different sites are collected, with the first and last being at least 1 hour apart. Exceptions to this rule can be made if the patient is super sick and needs help right away. But in general, you want those cultures done first. For most patients, IV vancomycin, represented by the recurring sketchy symbol, the vancomycin caravan, is an appropriate choice for empiric therapy. That's because it covers the most common culprits, staph and strep species, which is why this van comes from Empire Carriage Rentals. After blood culture results come back, you can and should tailor antibiotic therapy to the specific pathogen and its sensitivities. Regardless of which antibiotic you use, you must always use IV antibiotics to treat IE. We treat endocarditis with the respect it deserves. Because IE is such a serious disease, patients are given IV, that's right, IV, antibiotics for a total of 4 to 6 weeks. This is noted here by the window shades on this caravan. Notice how they all look like calendar weeks? One's got all 4 weeks, while the other has 2 more. You might have heard about prophylactic antibiotics to prevent endocarditis, but when do we give it? Well, nowadays, we're actually much more restrictive about handing out prophylactic antibiotics, represented by a recurring sketchy symbol, the PPX shield. Patients must have both a qualifying cardiac condition and be scheduled for a qualifying procedure in order to receive antibiotic prophylaxis. Qualifying cardiac conditions are pretty serious and include patients with prosthetic heart valves, previous endocarditis, unrepaired or recently repaired cyanotic congenital heart disease, or valvulopathy from a heart transplant. Qualifying procedures include deep dental procedures, not your routine cleanings, respiratory tract procedures like bronchoscopy, and procedures involving infected skin or soft tissue. That's why this caravan driver is doing a deep cleaning of his shotgun with his toothbrush. If prophylactic antibiotics are warranted, the regimen is pretty simple: a one-time dose of oral amoxicillin, represented by our recurring sketchy symbol, the ammo box next to our driver, 1 hour before the qualifying procedure. Let's wrap up this sketch with a brief summary of what we've learned. The term endocarditis most commonly refers to infective endocarditis, in which bacteria latch onto abnormalities in the heart valve and form growths called vegetations. The other big cause of endocarditis is non-bacterial thrombotic endocarditis, which is most commonly associated with malignancy and lupus. Lupus in particular can cause a form of MBTE known as Liebman-Sachs endocarditis. Unsurprisingly, the most common presenting symptom of infective endocarditis is fever. Endocarditis can produce a wide array of systemic complications, including heart failure due to valvular insufficiency and septic emboli, which can break off and cause neurologic complications such as stroke or brain abscesses, acute mesenteric ischemia, or PE. In general, infective endocarditis requires 2 conditions to form: a pre-existing heart valve abnormality for organisms to grow and form vegetations on, and a source of bacteremia, such as poor dentition or invasive dental procedures. IV drug use is a specific factor for endocarditis affecting the tricuspid valve. The most common pathogen isolated in endocarditis secondary to IV drug use is Staph aureus. The classic exam finding in IE is a new heart murmur. In fact, a patient presenting with fever and a new heart murmur has infective endocarditis until proven otherwise. Other less common findings that are specific for IE include Janeway lesions, Osler nodes, and Roth spots. If you're suspecting infective endocarditis, it's important to get 3 sets of aerobic and anaerobic blood cultures from separate venipuncture sites, each spaced at least 30 minutes apart, before starting your patient on antibiotics. There are a bunch of different infectious causes of IE, so let's quickly go over them. The most common pathogen overall is Staph aureus, which causes acute IE, especially in patients with implanted devices, prosthetic valves, and IV drug users. Coagulase negative staph, like Staph epidermidis, is a common cause of subacute endocarditis in patients with prosthetic valves and indwelling devices. Viridans group strep species, like Strep sanguinis, are the most common cause of IE in patients with native heart valves. Strep bovis complex is classically associated with colon cancer or IBD. Enterococcus endocarditis is rare and classically associated with urosepsis from nosocomial UTIs. The haystack bacteria are classically associated with subacute IE, producing negative initial blood cultures. Finally, fungi like Candida can cause endocarditis in immunocompromised patients. Regardless of the cause, the imaging modality of choice for the diagnosis of endocarditis is echocardiography. In most cases, transthoracic echo is the first step, but transesophageal echo is more sensitive and may be required to see the classic vegetations. Despite all these tests, diagnosis of infective endocarditis can be very tricky. To make the diagnosis, we utilize the modified Duke criteria, which are divided into major criteria, such as sustained bacteremia and documented endocardial involvement, and minor criteria, such as a predisposing condition, fever, vascular phenomena, immunologic phenomena, and unsustained bacteremia. A patient needs either both major criteria, one major and three minor criteria, or all five minor criteria to be diagnosed with infective endocarditis. Once the diagnosis has been made, treatment is pretty straightforward. IV antibiotics are the mainstay of therapy. For most patients, IV vancomycin is the most appropriate choice for empiric therapy. Once blood cultures return, you can tailor your antibiotics to the patient's specific bacterium and its sensitivities. If patients have a qualifying cardiac condition, such as a prosthetic heart valve or prior endocarditis, they should receive prophylactic antibiotics with amoxicillin before undergoing a qualifying procedure, such as deep dental work or respiratory tract procedures. Oh, man, this city's about to explode. I'd better get out of here before the beast gets out of control. Wait, is that a full moon? Oh, oh no!